can I invite the next speaker, Dr. Siva Shanmugam, for Ultrasound Guided Regional Anesthesia Fellowship in India, A Path Ahead.
Good evening, one and all. Actually, this is a tough challenge for me in 15 minutes' time to talk about fellowship programs in India, Path Ahead. So, first when Gopal sir gave me this topic, who am I to speak on this topic is the first question that came into my mind. Because what is the credentials that I have? What is the validity of the content of my slides? So I just sit back and reflected what I learned in these few years of teaching residents on regional anesthesia. I thought I will put back into the slides. So the disclosure is, this is my experience. So I request all of you to see the presentation from my perspective. But I'm sure you can very well mirror it to you as well as any one of the candidates in the country, because I am one among you. As far as a student, I'm a self-learner. I have not underwent any formal training for ultrasound-guided regional anesthesia. Before my embarking into the process, my thought process was, if I get my block working, my regional anesthesia is delivered. That is what my thought process. But after I went through my formative years for 3 years in ultrasound-guided regionals, what I finally learned was, putting the right drug in the right place in a right amount is just get your block working. But that can be completely inappropriate for the contemplated surgery and the quality of surgeon for whom you are putting the block. That, I think these two factors you can very well understand. Putting a perfect brachial plexus block for a fractured clavicle is inappropriate because you need a superficial cervical plexus block. And doing a posterior approach humerus for a surgeon who is going to operate for 4 or 5 hours, if you are trying to do only under block, it is like a sin. The patient cannot lie down under laminar flow at 20 degrees Celsius. It's not possible. So, and the third thing is fantastically working blocks, sometimes horribly rated by the patient, simply because I have not paid attention to their mind. I paid attention to their body. Procedural sedation and regional and general anesthesia is an integral part of regional anesthesia. We did not look at it different to entities. And so many times I burn my fingers because I have not paid attention to the environment in which I am practicing, the infrastructure and the backup that I have. Suppose if my plan A fails, what is my plan B? Is my system supports to it? So at the final conclusion at my formative years was, getting your block working is only 50% of the job. The remaining 50% is all about your soft skills. How much you know about your surgeon, surgery, patient, and environment is what going to create an appropriate environment so that you can deliver all the benefits of regional anesthesia to the patient. So with all these qualities and ideas in mind, I wrote a curriculum for 6 months in ultrasound-guided regional anesthesia and started teaching students. I come across 3 types of students. The main group, the majority of group is focused on skill. The moment they come, they wanted to get a chance and put a needle. Whenever I ask, do you know the innervations of the upper limb? They are stuck. Without knowing this basic issue, how you can put the probe onto the patient. But their aim is get a chance and then do the block. Even the people used to ask, sir, can I have a 2 months observership? I said, no. Sir, is there any exam? I said, yes. You have to read, you have to know the science behind it, then only you can get the fellowship. So this is the majority of the candidate attitude. Their entire orientation, it is skill-based, let me learn the skill. The second group is more of a theory-oriented. Moment if you ask one question, they will speak for 10 minutes. Maybe it is relevant or not relevant, that's a separate aspect. But they speaks more but do less. The third group is the minority group who has got a both good blend of knowledge and as well as the skill, but poor attitudes. They fights with everybody. Staff nurse complaint, technician complaints, surgeon complaints, difficult group to handle. But whenever I call them up, even my own colleagues, when they are used to tell me that your fellows are just poking the patient, they are not looking them as a whole, I used to think, what the hell am I doing? Whom am I creating? When I used to call them and talk to them, see, these are all the qualities that you should have. Getting the block working is not all anesthesia is. Moment I started speaking, they will look at like that I'm speaking some philosophy. It is a Siva Shanmugam way of teaching. I said, no, it is not my version, but these are all the qualities that you should imbibe to be a professional, basically, where it is written down. Are you testing me, my exam test me on all these aspects? No. So if not written somewhere and it is not professionally taught, if it is not assessed, nobody is going to interested in look into all these aspects. So my reflections at the end is students are diverse in terms of skill, knowledge and attitude combination and their values towards it. There is no written down document or a model to show an ideal regional anesthesiologist qualities. And there is no system or tool in place for me to train them on that direction. This is what my reflections at the end of when I analyzed as a teacher looking at a student perspective. Then when I took the position of an administrator as a fellowship program, I can able to read the mind of the teacher's mind, what they are facing. So now in the process, I trained 2 or 3 to 4 faculties of my department as a FUGRA faculty so that they can teach the students. When I interact with them and ask them how about the fellow is doing, 3 different consultants will give 3 different explanations. One is telling, yes, she is doing a fantastic block, her skill sets are good. The other one is telling, no, what she's doing, she's not doing good. Why? She's not respecting me. Okay, that's fine. That is an attitude-related relationship. What is about her skill set or knowledge? No, she's not reading at all. She's just blindly putting the block, but there is no knowledge aspect of it. The third one, how is she doing? He is telling, I have not seen her doing many blocks. Then I asked him, you are a FUGRA consultant. Did you make any attempt to see her? A few times I saw her. Sometimes her block fails. I used to tell him, you only taught her. Did you look at why her blocks fail? Stuck. So one candidate, 3 different conclusions from 3 different faculties. Which one you will take? So I thought, because each one of them looking at the candidate in a different dimension. One looks at the knowledge component and comment. One looks at the skill component and comment. The other one looks at the attitude, interpersonal relationships and comment about the candidate. In all these comments, it is not only the student, it is plus the mind of the teacher. All the time, their perception about the candidate is what projects more than the actual candidate himself. So my final reflections after this analysis is, even teachers didn't know that what are all the ideal attributes of a regional anesthesiologist. There is no system, method or tool to assess the candidate in all these dimensions, skill, knowledge, attitude, and reflect to them where they are. And their assessment most of the time was subjective than objective. So putting everything together, if I'm a student, these are all the questions I will ask to the administrator. What you want me to be there at the end of 1 year? I know that I cannot be equivalent to Dr. Sandeep Diwan or Bala Venkat. Then what you want me to do, be it? Can you define it? Okay, suppose if you're defining something, where am I now? So I don't know where I have to go, where I am now, and what is the roadmap? No idea. Then if I put myself into the teacher position, these are all the questions I will ask to the administrator. What is expected out of the candidate at the 1 year? I know I cannot that he can achieve everything at top level at the end of 1 year. Then what is the level will you accept? What is the degree of knowledge, skill and attitude will you accept at the end of 1 year? And how to assess him objectively? All the time you are saying that is your subjective. Can you tell me, is there any method to objectively assess him and rate a candidate? So the answer is competency-based curriculum. So what we have right now is a process-based curriculum, where I have written all the knowledge component. I will teach anatomy, physiology, physics, equipment, complications, pharmacology, etc., written down on the curriculum. We will take PowerPoint presentations. We will teach blocks on the PowerPoint. We assume that candidate will perfectly do the block in the OT. So we teach on one side, we presume the competencies. This is called process-based. Whereas the competency-based curriculum first define the competency, what he has to learn. For to do ultrasound-guided supraclavicular block, what are all the competencies required? You define that first and then write a curriculum to achieve it. That is a backward process. So what we have is a teacher-centered process. We have to convert into a student-centered process. Competency-based curriculum defines the competency in 6 domains. The medical knowledge is the theory aspect of your technique. And then the second one is a patient care, which is actually the skill of performing a technique. It defines all the components. And third thing is system-backed practice. When you are doing it, how you are adapting your local policies. In my department, certain blocks has to be done in the procedure room. You have to follow up all the minimum monitoring standards. You have to use an antiseptic precautions like this. Whether the candidate is following all those things or not comes under system-based practice. And the fourth competency domain is practice-based learning and improvement, self-analysis. How the candidate improve himself by critically analyzing his own process comes under that category. And then how about your communication, interpersonal communication skills, and finally the professionalism, how he conduct himself across all these duties. The competency-based curriculum clearly defines the acquisition of individual competency, but it doesn't analyze or it doesn't emphasize the integration and application in a real life. That is a disadvantage. For example, one of the fellow who has passed out the FUGRA candidate, he is the topper. He has got a good marks in the theory, and he has perfectly explained the steps of all the brachial plexus block. He has shown on to the volunteer. He is one of the best outgoing student. One time I was happened to see doing a 90 kg man, he is doing a brachial plexus block for a clavicle procedure. I used to observe him. He is good at brachial plexus, but he is weak at cervical plexus. He doesn't know how to identify different facial planes. The targets are difficult. It is a difficult case. He is looking for an upper trunk into the interscalene groove. It is not there. Actually, it is in the anterior scalene muscle. He is trying to search. He don't know what to do next. His knowledge is good. He has performed well in the theory exam. He has explained the skill set well, but this is what he is fumbling at the practical situation. He is a good language. In the meanwhile, I am observing the patient because patient was not comfortable lying down on a pillow. He is twisting and turning. He is explaining the patient, don't worry, we are going to give a block. After that, the pain relief will be there. Patient is not attending. He is about to give an fentanyl. I just held his hand and told him the patient has got rib fractures, 3, 4, 5, and 6. He cannot lie down on the pillow for any more time. We cannot do this case under block. We have to give a general anesthesia. You can give a block for intraoperative analgesia and postoperative analgesia. Make sure that we will look for a pneumothorax intraoperative period. We should keep ready things in case if you need to intervene with ICD. This is what is. As far as the exam concerned, he is a topper, but when in a real life situation, he couldn't able to deliver where integration of multiple competencies are required to suit to a particular situation, he is failing. So then we need an assessment system which actually assess all these competencies in a real life situation. So entrustable professional activities are developed to bridge the gap between the competencies acquired and application at the bedside. So what is this entrustable professional activities? It got two terminology. One is a professional activity and another one is entrustability. Professional activity is nothing but whatever the activity we do, we will make it as a professional activity. Giving spinal, putting a supraclavicular brachial plexus block, taking an informed consent. So all the work that a resident will do during a fellowship program converted into some kind of a professional activity. And then entrustability is how much I can entrust or believe the candidate that he can perform without supervision. So entrustable professional activity is nothing but the trainee is entrusted to perform without supervision at the end of a training period. The entrustability can be at a 5 level. Level 1, he is a novice candidate. He don't have any skill set or knowledge to do that particular task. He can only observe. First 2 months of fellowship, candidate can only see me how I am doing a block. The level 2 is a tight supervision zone. The next 2 months of the fellowship where I will do the 70% of the work, assist him, he will do the 30%. On-site tight supervision, he can do it. It is called advanced beginner. The level 3 competency is where he will do the 70% work, I will help him out only in 20-30%. That is called a competent person. Level 4, who can perform independently, I will do only remote supervision. If he calls me only, I will pitch into the situation. Level 5 is an expert who can teach, train, innovate, and do research. So, I divided all the work that a fellow is doing into multiple professional activities and rate them 1 to 5 scale. My aim is to get him to a level of 4 at the end of training program. Madam, I will take 2 or 3 more minutes. Yeah, thank you. How to build up a EPA for a fellowship program and how to rate the EPA in an objective manner is what we are going to look at now. So here, this is the EPA laid down in the fellowship program. If you look at all the blocks that has been divided into multiple EPAs, So for lower limb blocks, each block will be assessed in all the 6 competencies: medical knowledge, patient care, system-based practice, communication skills, PBLI, and professionalism. And what they have to achieve at different months has been laid down. So all the professional activity, all the blocks has been converted into a professional act. So we got almost 22 EPAs. And each EPA, whenever will be assessed in all these competencies. First, if you take medical knowledge, the medical knowledge itself will be assessed on 8 categories. Moment before the candidate touches the patient, I will ask all these 8 questions. Innervation of the surgical site, what are all the other factors will affect the surgery, approaches available, among the different approaches, which one you will choose, after choosing, what are all the drug dose that you will use, and how you will assess the block, how you will do a rescue measures, if it fails, if you expect any complications, how you will manage. So any one single block, before touches the patient, he should answer on these 8 different dimensions. Then only he can eligible to hold the probe. When he is doing a block, his skill set will be assessed on all these 6 dimensions: ergonomics, image acquisition, optimization, interpretation, needling, and optimal LA locations. And then the system-based practice, we have a clear-cut laid-down protocol, standard operating protocols in the department. He should follow 100% of the things in all the blocks. Whether he is following yes or no will be rated. So in the each theory questions, we will rate him on a scale of 3, 1, 2, 3. What is the 3 answer also we will define. So if you tell all those things, you will be given a mark of 3. In between 2, the teacher can rate him 1 or 2. So similarly, his communication skills, his professionalism, all those things will be assessed. And then finally, it will be converted into a EPA level. If you look at, this is the maximum score what he can get. So if you get a 40% marks, we will be get a level of 2. If you get 60% level of 3, if you get 80% only, we will go to the level of 4 EPA. So now, if you have a candidate, if I ask me what you wanted to me at the end of 12 months, I will tell for doing an ultrasound guided costoclavicular block, you should reach a level of 4. If you ask me what is mean by level of 4, I will tell him you have to gain 80% in the medical knowledge, 80% in all the 6 competency domains, and 100% in the practice-based learning and improvement. You should score 74 out of 92. If you ask me what you mean by 80%, I will clearly tell him these are all the 80%. The 20% where he is lacking also I can able to project to him. So now where I am now, at the 3 months you are only at a level 2. What is mean by level 2? You are only at 40% in terms of medical knowledge, and all the things I can pinpoint where exactly he is landing up now. What is the roadmap? You have to reach level 3 at 6 months. You have to reach level 4 at 9 months. So now, what is the path ahead? ARA should make an accreditation council, academic accreditation council, clearly lay down the competency-based curriculum and the EPA pathways. We can debate on which one level 3 has to go, which one level 4 has to go. Candidate may not reach level 4 lumbar plexus block at the end of 1 year. All those things we can define and then put across pan-India, single curriculum, single assessment method, and similar way of expression of competency. So when Pondicherry, when I say he can do a level 4 lumbar plexus block, Sandeep Diwan can clearly know that what is mean by level 4 in terms of knowledge, skill set, attitude, so that both the candidate also know where he is, both the teacher also know where he is. So now to conclude, I just reminded upon the words of Dr. George Gregory, so I thought I will put it up here. My goal has always been to make the resident and fellows better than I am. I have thought that if the resident and fellows finish the program and are not better than I am, I have failed. It does not always work, but many times people turn out as good or better than I am, which is enormously satisfying. Without that as a goal, you are wasting your time as an educator. So I thought I will reflect this here so that we should move forward in these directions to be a good educators. Thank you very much for your kind attention.
Thank you, Dr. Siva Shanmugam, for your excellent presentation.